Welcome back. We're going to finish up with intraoperative patient care and discuss common surgical positions. This can be found on figure 1710, page 280 of your IGGI book. Typically when the patient arrives in the surgical area in the operating room, they're in a supine position after they transfer onto the operating bed. Typically anesthesia is initiated when the patient is supine, and then once that anesthesia is given, the patient will be repositioned for surgery. The circulating nurse is basically the coordinator of positioning of the patient. Factors influencing the timing of repositioning are going to include the surgical site, the age and size of the patient, anesthetic delivery technique, and if the patient has pain on movement, if they are conscious. Other factors that will influence the actual position include the specific procedure. So obviously if one of your patients is in lithotomy, they're probably having some type of perineal, perirectal, perineal type surgeries being done. What is the surgeon's request? It is good to think about the patient's age, size, and weight. And then if they have any pulmonary, skeletal, or muscular limitations, so if they have arthritis or if they have joint replacements, emphysema, things such as that. Our best outcomes for our patients is to prevent complications from long-term immobility. So obviously the potential for injury is going to occur for patients due to the positioning. We want to make sure that we are preventing any pressure sores. We want to ensure that our patient has peripheral sensation and motor function after surgery. So we want to do that really good assessment in the preoperative period so that the patient can be assessed postoperatively and ensure that they have the same functioning level, same sensation level as before surgery. We are also going to ensure that there's any absence of skin redness or any open wounds, open areas once surgery is completed, as well as any bruising. During the surgery, it's going to be important to check for peripheral capillary refill, peripheral pulses, and ensure that we are following good interventions to prevent injury from happening to our surgery. And those are listed out on your slide, and they're also listed out on page 280 of your book. Many patients run the potential of infection during the postoperative period. Obviously, if we've had an invasive procedure done, we've been cut open, we've had incisions made, we've had injections, those types of things. So the goal is that our patient is expected to have an uninfected surgical wound or wounds, but be aware of what the indicators are for wound infection. So taking a look at those wounds and ensuring the edges are closed and not excessively red or swollen. The wound is free from any purulent or pus-like drainage, and that our patient's white blood cell count is remaining in normal limits or what is expected postoperatively. And interventions would include utilizing plastic adhesive drapes, always good hand washing and maintenance of aseptic technique, utilizing skin closures, sutures, and staples, especially non-absorbable sutures, so that we keep the approximation of our wounds intact. We want to ensure that we have maintained the surgical dressing for at least 36, oftentimes 72 hours postoperatively, so we're not taking those post-op dressings off prior to those wounds starting to granulate and starting to heal. So we want to make sure that we do keep those dressings on. If your patient is saturating those dressings, however, and they need to be changed, probably your best intervention is going to be to just reinforce those dressings so that it absorbs the drainage. And then patient transferring from the OR table to the stretcher. It's just going to be important to maintain our patient's safety. Utilizing a roller board or a lift sheet to move the patient from the operating bed to the stretcher. Sometimes patients will be able to move themselves, but we want to make sure that they are safe and reduce any potentiality for infection. Potential of hypoventilation. The expected outcome in the intraoperative period is that our patient will be free from any damaging events. So we want to make sure that we are watching the pulse oximeter, that we're watching the capnography for carbon dioxide, watching blood gases, checking vital signs, make sure they're within normal limits, and then returning to pre-surgical level of cognitive functions. So it's going to be important for the nurse, surgeon, and anesthesia to monitor the patient and be very cognizant of how our patient is doing. Finally, we want to just discuss types of skin closures, and this is on page 282 of your IGGI book. And common skin closures, what you will see are interrupted sutures, continuous sutures, maybe staples, a retention bridge or maybe retention sutures, and then also tapes such as steri strips, things like that. So it's going to be important to look at these incisions, make sure they're free of any signs or symptoms of infection, and then make sure that our patients have moved through the preoperative and intraoperative periods without any incidents and do not have any injury related to surgical positioning or equipment, and maintain their normal body temperature. So the following slides are questions that you have, and I will just pause the recording on them, allow you some time to think about them, and then we'll discuss them in class. Thank you for your time and attentiveness to this intraoperative period, and finally we'll be able to finish with the postoperative period and pain management.